Good evening, everyone. Dr. Amin from Toronto. Such a pleasure to be with all of you tonight. Great to see you all from Toronto, snowy and cold Toronto. Great to see you. So tonight we're going to talk about hormones as such an important topic, hormones that can influence us in all ways. They can influence everything in our body. They influence our mental health, the metabolism, energy, sleep, even emotional well-being. So everything. As a functional and metabolic regenerative doctor who's specialized in hormones and menopause, women's health, I've seen firsthand how important these hormones and how optimizing understanding hormone can be truly life-changing. And tonight we're going to talk to Dr. Tami, one of the best in this field. So I'm going to invite Dr. Tami tonight. And if you have any questions, do not hesitate to drop it here in the comment or the question bubble. We try to go through those questions, and as I always say, don't forget this platform is not for personal medical advice. It's just to increase your knowledge, so empower you to be able to advocate for yourself, to go and talk to your doctor about those little symptoms, the changes that you thought those are all natural changes and you accepted it. You go and talk and discuss about your concerns with your doctor. So I'm going to invite hello.
Hi,
Hi,
beautiful.
Dr. Tami. Good to see you and pleasure to have you here
Oh,
tonight.
what an honor. And thank you so much. It's fun to see each other on online, but then when you get to see and connect in real time, it's even more beautiful. So thank you. And there's just so much confusion out there about hormones and perimenopause and menopause that I've been doing this for 15 years. I'm so excited to help just get everybody settled in with some data so that they can be the CEO of their own health.
Exactly. That's I was just saying about everyone to hopefully empower everyone to be able to advocate for themselves and talk about those changes, those symptoms that they were just thinking it's natural or it's okay to accept and not do anything about it. So that's, I think it's good to empower everyone.
Absolutely. And this is when a woman enters perimenopause and menopause, I feel like it's a unique opportunity. It's your turn. It's your turn to put yourself in the front of the line. And not in a selfish way, but in a self-love way.
Mhm. Very good. Good. We should all learn to love ourselves.
Yeah, more each day.
Mhm.
Exactly.
Yes. So I received some questions that I would love to share with you and hear what are your thoughts about those questions. And as I said, if we had chance to answer some questions here from the audience, we will take those
Great.
too. So one of the questions about postmenopause woman who's struggling with all those symptoms like brain fog, weight gain, so many different symptoms, sleep problem, but not hot flashes. And she has approached her doctor, and doctor denied prescribing hormones. So she's asking, what should she do? Is there any other option for her? How can she address the problem?
So, first of all, there's over 60 symptoms of menopause. So, just to say just because you don't have hot flashes isn't a problem doesn't mean you're not having menopausal problems and menopausal symptoms. You likely are. There's things like shoulder pain, back pain, itchy ears, um, Yeah, anxiety, joint pain, skin being dry. There's so many. Plantar fasciitis. There's so many that we're just not getting addressed. There's a beautiful study by Dr. Vonda Wright recently published called the musculoskeletal syndrome of menopause. All your aches and pains are because of your hormones leaving your body. So my advice or my recommendation is find a provider that knows what they're doing. If somebody only has the criteria of hot flashes in order to have a conversation with you about hormone replacement therapy being an option to help you, then they don't know enough. And your doctor works for you. You can fire them and go hire somebody else that's more up on the latest. You know, you're an expert in functional medicine and a specialist, but we didn't learn this in med school, right? And to this day, there's no education in medical school about menopause and hormones. We had to spend a lot of time, energy, and money going to courses and getting certified and learning this. And, you know, when I wrote my book, The Hormone Secret, I dove deep into the research and there wasn't a lot. So it takes effort and you need to find the people that are out there. There is a ton of doctors. They're just, sometimes you have to do a little scratching under the surface.
I agree. Listen, ladies, so don't lose hope. There's always someone else you can approach and ask your concerns and just talk, discuss your issues. I totally agree with you. So, next question, which is a very common day, everyday concern of everyone about breast cancer. So I keep hearing not only from my patients, but from other doctors, other providers who are concerned not prescribing hormone therapy with a concern of breast cancer. And does this mean the HRT then is completely out if there's a family history, my aunt, my cousin has a breast cancer, so what should I do?
So what I want everybody to do is just to like never believe somebody, not even your doctor. Like if a doctor tells you one thing and if you've heard something else, then say, "Hey, could I trouble you to share the research about that?" And if there is no research, then you know that they're just going by this old training that they had that is no longer accurate. We know without a doubt that taking bioidentical progesterone and estradiol does not increase your risk for getting breast cancer. It does not. In fact, it shows that when you take bioidentical estradiol and micronized progesterone, you live longer and die less of all causes, including cancer. Recent studies showed that taking low dose testosterone reduces your risk of breast cancer. So why the confusion? Like, where does this come from? Well, it's not out of the blue. The Women's Health Initiative study, which was done a long time ago, was very misunderstood and misrepresented, and generations of women were ripped off of their hormone replacement therapy and weren't offered it. To this day, it's still one of the reasons. And what they found was that there was an increased risk of breast cancer with progestin. Now, the problem is this sounds so much like progesterone, and a lot of doctors mix them together as if they're the same thing. But I tell you, if you saw those chemical structures side by side, you would not call them the same thing. They are so different. So if you're being told, like last week, I had a patient come and she went to get her pap smear and things like that. We do functional medicine. I want you to go to your regular doctor where your insurance will pay for your pap smear, etc. So she went and her regular gynecologist said, "You're on 200 milligrams of progesterone." She didn't start there, but that's where she ended up because that's what she needed to help with sleep and to balance her estrogen. So it's micronized, bioidentical, FDA approved. It's the right dose for her. We've tested, we've evaluated. And her gynecologist said, no, I want you to stop that. I want you to take 100 milligrams, because she said 200 milligrams was associated with breast cancer, but 100 milligrams wasn't.
Very strange.
Oh, where did
This is so, this is new.
right? This is a new one. So I said to my patient, I'm like, okay, so this is the first I heard that it's dose related, but the craziness continues. No, you're not going to get, you might get breast cancer, but not because of your bioidentical hormone replacement therapy.
Yes. So definitely, of course, we have to assess each case differently, individual and personalized treatment, but the evidence is there out there telling us that, especially with estrogen, there is no increased risk of bioidentical estrogen, no increased risk of breast cancer. And as you even said, it reduces risk of breast cancer.
And I think it's important to remember that, you know, the risk if your grandparents had it versus your risk if your mom or your aunt had it versus the risk if you just had it is different. So you need to find a provider who knows that if it's, you know, your parent or your grandparent, then that's not, that isn't a reason to not get it. If you have had breast cancer, then there's a more nuanced conversation to have. You know, there's vaginal estrogen to help. We know that's safe. So you really do have to find, no matter what your family history or your personal history, find somebody who can go through the fear and find the data.
I totally agree. Another common problem that I see, and patients come and see me, is that my provider, my gynecologist, is advising me to stop hormone replacement therapy because I'm reaching age 60 or I'm 10 years now on hormone replacement therapy. Please help, because if I stop, I start having those horrible hot flashes that won't let me to sleep at night.
So I'm turning
So
60 this year, and you'd have to like take it out of my clenched fist if I even forget one night to, like, if I go a few extra days to switch out my patch, I'm like flinging off the covers and just, you know, hot and bothered. So the Menopause Society presented in 2024, at the end of 2024 at the meeting, research that showed the benefit of having hormone replacement therapy in women in their 70s and 80s. And what we know particularly is that, fortunately, one of the benefits for hormone replacement therapy, especially estradiol, is bone health. Unfortunately, when you stop, that benefit goes away. So since osteoporosis risk increases as we get older, it makes no sense to stop the thing that's the most benefit to preventing it just because you've turned randomly 60. And, you know, your skin loves it, your cardiovascular system loves it, your hair loves it, your brain loves it, your sleep loves it. Yeah, we now have proof that it's safe. So again, work with a provider. It's personalized. That doesn't mean you have to take it. It just means you can, and you can find that conversation to see if it's right for you.
exactly. It's a very personal decision, as long as you know and aware of all those information, and then you can decide if it's for you having hormones or not.
Right.
So again, one of those questions that always I receive is about bioidentical versus the traditional hormones. What's the difference, and which one is preferred way of treatment?
So I think that this needs to be like a whole like little tiny master class for everyone, because it's so crazy making. Every single thing is synthetic because it's made in a lab. Even your natural stuff, even your vitamins, like everything except for your food, well, even some of our food is made in a lab, but I wouldn't call that real food.
I know.
So even your bioidentical is synthetic, meaning it's made in a lab. So I like body similar as the word. I get bioidentical. I use it because it's understandable, but all it's trying to say is that its shape, its form, and its fit into the receptor is as good as we can get to the real thing. So we're replacing exactly what we lost in the same form. And whether or not that is true, we call bioidentical the one that is body similar, and we call the synthetic ones like progestin the ones that are synthetic. But in fact, they're all made in a lab, and you want it to be made in a lab, because when I say to you, I want you to take 0.5 milligrams of estradiol, I want to know that's what you're getting. I don't want it to be random, one dose one time and then inaccurate the next. So it's good. What's more important, and what I would prefer people to focus on, is the route of administration. It is after you've gone through, is this body similar? Then how are you getting it into your body? If you're having sleep disturbances, oral progesterone has been shown to be more effective. If you need to get that protection of your uterus up because you're well into menopause and you need a higher dose of estrogen to get rid of the hot flashes, then oral is easier to get to the dose to protect your uterus. But you can do topical progesterone. I like oral because, I love the sleep benefits. But when we get to bioidentical or body similar estrogen, I do not prescribe oral estrogen, even oral estradiol, even if it's bioidentical. And here's the reason. There are some benefits. The research is clear, but there's also a small but real increased risk of clots when you put estrogen in your mouth. And it goes through the GI tract and into the liver and through the cytochrome P450 system. So why risk that? So you've got creams, you've got gels, you've got all kinds. Oh my goodness. That's a celebration about how much safe ways you can get bioidentical estrogen.
Exactly. That's amazing. So many different ways. But I agree. I mean, that's what I normally prescribe, oral progesterone and transdermal estradiol, and also transdermal or topical testosterone. That's what I normally prescribe to patients.
Yeah, that's the way to do it when you're practicing,
Yes.
functional medicine. That's the most up to date, I think.
Exactly. So now we are getting to another very common question I receive from patients about starting hormone therapy. I started a few months down the line. I'm much better, more energy, hot flash almost gone, but I've gained some weight. I feel puffy. I feel some swelling in my legs or in my body. Is it due to hormones? What are your thoughts? Have you had that experience with any of the patients telling you that?
I have, I've been, when you do things for 15, 20 years, you hear a lot of things. I still see patients, we have a nationwide clinic, have doctors with licenses in all the states, and I get to see patients every day as well. So one of the things that I want patients to know is that it needs to be personalized. And not only do you need to replace the deficiency, but you need to balance everything. Your hormones are like a symphony. And if you're getting puffy and gaining weight, perhaps your estrogen dose is too high. But it might not be. Perhaps, our estrogen gets processed, and the stuff that's not used anymore, it's supposed to go out through a process in the liver, but some people have like a lazy liver. It's just a little slow. And so you have to adjust the dosing schedule. Maybe if you're using cream, instead of using it every day, you use it every other day to give your body time to get rid of it. So that's where the personalization comes in. So I would say if you have these side effects of feeling puffy, gaining weight, etc., it's not the hormones fault per se, but it's the balance. Does that make sense?
It does make sense, absolutely. Especially as a functional doctor, I think it makes sense because we have to work on detox too, make sure detox pathways are open. So it's not only just to put the medication inside the body, but to make sure we are metabolizing and getting rid of the excess and their balance, as you said. It's so
And
important.
there's no one optimal dose for everybody. There just isn't. It's, you know, you can go to Starbucks and you can get the exact same drink anywhere in the world. That is the antithesis, the opposite of what your hormone replacement therapy should be. It should be customized for you. And what's right for you is not necessarily right for somebody else. And what's right for you 5 years ago, 3 years ago, may not be right for you right now. So you really have to remember we're a dynamic living organism and things continuously change.
Yes. And sometimes it's a matter of waiting and giving some time so
Yeah,
your
that's true.
body gets used to.
Yeah, that's true. I always tell my patients, you have to make sure you give your body time to believe you.
Mhm. Yes. Yes. Um, yeah, again, someone is asking the same question. So I've been an HRT for a few years. When is time to stop? Should I stop if I feel good? Or what are the precautions? What should we steps to take if I want to continue taking it?
I think just making sure that it's the right dose for you as you age. But yes, you can take it
As long
well.
as
No, there is no age to stop that we know of yet.
I know. Again, a question about what are the tests? Should we do some screening tests whilst taking hormones, mammogram or pelvic ultrasound, pap test? So do those tests or diagnostic tests. Should we do those tests? How frequent? What are your recommendations in practice?
Well, I think you and I are similar, right? So we practice naturopathic integrative functional medicine, but we went to traditional medical school. And you can never get rid of that really solid training about diseases and conditions, because that's what traditional medicine is focused on. People don't have health insurance, they have sick insurance, and thank goodness, but it has nothing to do with wellness. So we do want to make sure that you're getting your screening test to see if you have anything that could impact your vitality and your longevity, like getting a breast evaluation, mammograms. You know, there's a whole conversation about mammograms, there's thermograms, there's a lot of different alternatives these days, but you should be getting a breast evaluation. Pap smears, you know, that's important. If you have no new sexual partners, probably every 3 to 5 years is the recommendation when you're getting older. Colonoscopy, that's super important. You know, you don't want to get colon cancer, and a colonoscopy is like this magic, like screen, treat, fix. I mean,
Yes,
it's like a one-stop shop.
exactly. 10 minutes.
Yes, it's awesome. I would add to that a coronary calcium score. You absolutely should get a coronary calcium score. You should be insisting that your doctor order one, because cardiovascular disease is your #1 killer in menopause. You need to know how much plaque is or is not there in your heart arteries, because your cholesterol is likely to go up. Having bad cholesterol isn't the only thing that leads to a heart attack and stroke, but it's definitely one of the things we have to pay attention to. But take a look. And a DEXA bone scan.
Mhm.
It's so much easier to turn around osteopenia, which is thinning, rather than osteoporosis. And it's easier to adjust the dose. You might feel fine and good on your current estradiol dose, which is
Yeah.
like the bottom of the dose scale. But we might bump it up a little bit if your bones need the support. Like, what a wonderful medication to use as the treatment to help your bones. So yeah, and remember, there's alternatives. There's people who, I have patients who say, I'm never going to get a mammogram. They
Yeah.
terrify me, et cetera.
Someone is mentioning here,
Yeah.
she's scared.
Dr. Jen Simmons is a dear friend and colleague. She has a radiation-free
Yes.
type of mammogram. I don't think I'm supposed to call it a mammogram, but it's a breast evaluation. There's so many options these days. MRIs, there's those full body scans, there's thermograms. The point is to get a breast evaluation. Mammograms are something that are uncomfortable, and yes, there's radiation, but there's probably more radiation in a airline trip to Europe. So I'm not saying that they're the best thing for you, but I'm saying you need to take a look.
Yes, I agree. Talking about calcium score scan and checking the lipids, we see significant, drastic, sudden increase of cholesterol in women, perimenopause and menopause. So, and one of the main risk factors of death in women is cardiovascular heart attack. So, how do you assess patients when they get to see you about lipids
Every
and
patient,
risks?
yes. So I go beyond what I learned in medical school, and some of my colleagues who are cardiologists are doing this, and then other functional medicine. So the ones that I like that are sort of outside the norm are ApoB. That's called apolipoprotein B. This is a really, really good sort of bad cholesterol test. Another one is LP little a. There is an LP capital A. That's a completely different test. But you want to test for that because that tells us whether or not your cholesterol and your cardiovascular risk has a genetic component to it, which will allow us to approach it quite differently. The coronary calcium score, for sure. I also want to know, I feel like getting a heart attack or a stroke or having a heart attack or stroke is kind of like a destination we don't want to go to, right? It's a town. And you only get there by train. And you have to go to the train station, you have to buy a ticket, you have to walk on the train, you have to find your seat, you have to sit down, you have to put your seatbelt on. And then the train has to go over bridges, and it has to go through tunnels, and it has to go around corners before it reaches heart attack and stroke town. And all those bridges and tunnels and corners are oxidation, inflammation, glycation. All these things have to happen. So if you have an elevated LP little a, your parents drove you to the train station, bought your ticket for you, grabbed your hand, walked you on the train station, sat you down and buckled your seat for you. Thanks. But that's the way it is. And then one of the things I mentioned was inflammation. So there's something called heart specific, high sensitivity or cardiac specific C-reactive protein, CRP. That tells us how much inflammation is really bothering the heart. So that's another test that we can check for. And then we keep going further and further. Like if this is abnormal, then we go over here. If this is abnormal, we go over there. You don't want to test for every single solitary thing under the sun right away. You don't need to. There's myeloperoxidase tests. There's all kinds of soft plaque tests in addition to hard plaque tests. So it's a process, but ApoB, LP little a, HS or heart specific C-reactive protein, and a coronary calcium score is a really good start, I think.
It's a great start. Yes. Someone was asking if that QT scan is
Oh, that's what Dr. Jen does.
But
QT
it's
imaging.
if we
That's
have it
it.
here, if
Yes.
we have it here
Thank
in
you.
Toronto, in Canada, I don't think so. So to answer, I don't think so. I talked to Dr. Jean, and I actually one of our talks, I asked her she should bring it here too, and we should probably have a center, but I don't think we have one of those centers yet or a diagnostics test here.
You know I'm Canadian, right? Yeah.
Really? I didn't know.
Yes. We find each other everywhere, don't we?
Oh, so cute. So, another interesting question about taking perimenopause. In perimenopause, starting earlier hormone, can one start early taking estrogen or progesterone if needed? In this case, this is a lady who is in her 40s. She still has her periods on and off, and she already has Mirena or Mirena coil for heavy bleedings and contraception, but she has severe PMDD and symptoms before her periods or now because she has Mirena spotting. So she has started taking cyclic or cyclical progesterone, which helped her. But can she take every day, for example, progesterone?
This, perimenopause is a real roller coaster ride, and that's where you really need to work with a doctor that you have a relationship with and that you can have an ongoing conversation, because it's almost like what's right one week is wrong the next. And if you're, I feel like just not testing at all and just putting women on estrogen and progesterone in perimenopause is a disservice to them. Those are the women that are going to have estrogen dominant problems because their estrogen is going up and down and up and down. And when it goes up and you've given it to her, she's going to feel awful. She's going to feel cranky. She's going to have sore breasts. She's going to feel emotional. It's not fun to be having too much estrogen. So that's the time where I think that even though the lots of conversation about don't test because it's different all the time, I think you should test, and you should test often, every 2 to 3 months, and find out what's your highs, what's your lows, test at different times of the month, because you do want to have a low level of support of hormone therapy. And usually progesterone leaves us first and it leaves us fastest. So that's the one that's safest to start and usually makes women feel better. I would say there's somebody asking about when should they have the conversation. Your perimenopause starts in your late 30s. Your progesterone is leaving you in your late 30s, and that's the time where you might benefit from this. So
The sooner
it's
the
oh
better.
yeah, the sooner the better, because you don't want to wait until you fall off the cliff. You don't want to wait until you're having hot flashes. You don't want to wait until you're miserable before you start getting some. And the risks that we know of right now, they're not none. But we have been doing hormone replacement therapy. I mean, I've been doing hormone replacement therapy for almost 20 years. There's decades and decades of research. And when we're replacing what our body has already lost, I kind of have a pet peeve with this thing like you're copping out and you're not doing it the natural way when you're using hormone replacement therapy. I think that's such a disservice, because there couldn't be anything more natural than replacing what you lost with exactly what you lost. In fact, I think supplements are more unnatural because they're not identical. You're not getting to the root cause. You're not addressing the exact problem with the exact solution. So the risks are different for each person depending on their family history and their history, but the risk of cancer, I would say the benefits are so great. Every single solitary person, every single solitary woman should be having a conversation about that as a possibility with their provider, so they, as the CEO of their health, can make an informed decision.
Yes, have that conversation with your doctor, and the sooner the better. And
Yeah.
all these talks and conversations is for you to hopefully increase your knowledge and go and talk to your doctor about your concerns about the symptoms and changes in your body.
Yes. And we're worried about the risks of hormone replacement therapy. What about the risks of not having hormone replacement therapy? You know, Dr. Lisa Moscone, brilliant scientist. She's Italian but lives in New York. She studies the female brain only, and she focuses on the female menopause brain. And she has tons of published research that shows that if you start hormone replacement therapy within the first 6 years after your last menstrual period, it decreases your risk for dementia. Your brain literally shrinks when estrogen starts to leave. That's why your brain fog, your brain isn't working as well because it's not working as well.
And don't forget that we women are more at risk of having dementia, Alzheimer's disease. So it's so important to look after ourselves.
Yes, absolutely.
Yes. So that brain fog, exactly, you just brought it up. So what are the symptoms? As well as brain fog, we know so much emotional problems as well. And that depression, I get that a lot with my patients and seeing me, their providers, again, not prescribing them hormones. So what are your thoughts and experience with brain fog and emotional problems during this time?
So progesterone, which again leaves us in our late 30s and rapidly goes from there, has been called the Valium that bathes the female mind. It's our peaceful hormone. If you're waking up between 2 and 4 in the morning wide awake, you're not waking up because you have to go, then you have a progesterone deficiency or cortisol. But it's usually progesterone first as the let's figure this out. So progesterone when it leaves, it can make anxiety and depression that you had worse, or it can pop up for the first time. Panic attacks, etc. So mental health issues are some of the very first things that are a symptom of perimenopause and menopause, and they're just not getting addressed as a hormone, potentially a hormone problem, and women are just getting prescribed antidepressants. And antidepressants have their place, but why not also include the possibility that it's a hormone deficiency, especially progesterone? And so when we give women a replacement of their bioidentical progesterone, especially in oral form, because it helps get up through the blood-brain barrier, they feel better. Their brain works better. They sleep better. They feel more peaceful. And I don't know if that's just because you're having better sleep, because that certainly makes the whole world look better, or whether it's both. But I do know that progesterone is the peaceful hormone. And when it leaves us, it does not leave us peaceful.
I agree. What about, again, now we talk a lot about testosterone. We better not miss testosterone.
Yes, so I
Our
wrote the
male
book.
hormone,
I
as they call
know.
it, male hormones.
Well, my book, The Hormone Secret, I wrote it almost 5 years ago. I can't believe it. Before all of this was being, mainstream.
Yeah.
And The Hormone Secret is about testosterone for women.
Mm.
And we actually make more testosterone than we make estrogen. We have a ton of testosterone. When we lose it, I don't know why it's not being addressed at all. I don't understand. Because if you have so much of it in your earlier years, why is it completely disregarded? And then with regard to the replacement, oh my gosh, such a tiny bit goes such a long way. But it has an outsized role in how we look, how we feel, and how we function. And I have found that energy and muscle fat ratio and weight loss are the top three. Yes, libido, but that's more on the male symptom list. Higher up for females, libido is naturally going to go down once Mother Nature has invited you to no longer procreate. Now, that doesn't mean that it can't be a wonderful thing, but it's not going to be popping up in your brain, which is what libido is, right? You're thinking of and you're desiring it. So that is not going to be the same as when you were younger. And it just is what it is. It should be beautiful. You should love it. It shouldn't hurt, but it's not that. Testosterone gives you strong muscles, strong bones, makes your brain work. When I evaluated my hormones when I was in my 40s, I was so tired. I would literally lay on the floor under the desk between patients. I was so tired. And I was like, okay, well, I must be anemic or I must have a hypothyroidism. So I ran the usual
Yeah.
tests and everything was fine. Oh boy, hate that word. Nobody wants to be fine. They want to be fabulous.
Mhm.
And fine is a 4-letter word. So then I did my hormones. I was like, well, they can't be a problem in my 40s, but let's just check them. But I didn't check testosterone, right? Because I'm an MD. I was an MD, and I just like, that's not part of what we do for a woman. And they were fine too. And then I checked my free testosterone, and it was undetectable. I had none. And as soon as I replaced my testosterone, my life and my energy came back.
It's very interesting. So that's why it's so important. It's so personalized.
Yes.
I have exactly a very similar patient who doesn't need estrogen or progesterone yet, but testosterone is doing her so much benefit.
That's that's great.
Yes. Someone is asking about progesterone when having had a partial hysterectomy.
What we know about, I think what they're saying as a partial hysterectomy is that your ovaries are left, but
Yeah,
I'm not sure.
because
But we do know that even if your ovaries are left, like our bodies are so interconnected that when you take all the uterus and the cervix and everything out, you have disrupted some of the blood supply and how the ovaries work. So we do see in many women who had a hysterectomy, but their ovaries were left, that their menopause onset is a little bit quicker, a little bit more rapid of a downfall. And so I always tell female patients, if you have had any female surgeries down there, partial hysterectomy, left one ovary, left both ovaries, then it's time to check those hormones on a regular basis.
Mhm. I even had a patient who, in her 70s, not having any hot flashes, she was absolutely fine. She had to go through hysterectomy, and as soon as having hysterectomy, still having ovaries, started having severe hot flashes. Very, I mean,
Uh,
it's such a disruption to a system that I think she suddenly started having hot flashes once again
yeah.
in 70s. Yeah,
Wow.
very, very.
How
Mhm.
unfortunate.
It is.
Oh,
So
miserable.
we had to start talking about HRT again.
Luckily, we know it's safe.
Yes, absolutely. It's safe. And one last question, if you don't mind, I'm going to ask you about, um, yeah, so it was about stopping about the dose of the estrogen and progesterone. So how to choose, um, because we have 100 milligram progesterone and 200 milligrams. So when should we take 100 and when should we get 200 milligrams? Is it depend on the estrogen levels or what the dose of estrogen we're taking?
I never start at the higher dose. I just feel like if you come to me and you have undetectable progesterone, I can't take you from none to optimal overnight
Mhm.
and expect that every single one of you is going to handle it beautifully. I would rather just start low and go slow and sneak up and figure out what the best dose is for you. So I have a different philosophy. I'm going to create a relationship with you. I want your hormones to create a relationship with you again. And I don't want them to barge in. I want them to knock on the door. I want them to be let in and then see how much of the house that they're invited into.
Absolutely, yes. As I don't know if you know Dr. Pamela Smith, she always used to say, start low and go slow. That I
Yeah.
agree. in many cases.
Yeah.
That is good. I think in her context is about endometrial protection. If it's higher doses of estrogen, then should she go on a higher dose of progesterone to cover and protect her endometrium? I think that was what the question is about.
Likely, eventually, yes. And, it's unfortunate that the FDA approved bioidentical micronized progesterone is in a 100 and a 200. Like, you can just take two of the 100s. You should have made a 50.
I know.
Because sometimes that 100 to 200 is a big jump.
It is a big jump, I agree.
Yeah, and
I
that's
mean,
where the
there
compounding pharmacies come
exactly.
in.
Yes, I do in rare cases have to take the 50 from compounding.
Yeah.
Yes, yes. So it was lovely talking to you. It was
You
great, Dr.
too.
Tami. It
Thank
was
you
such
so
an
much.
insightful talk, and I share to save it and put it out for everyone so people can go back and check. And where can do you see patients? Where do you see
We
patients?
too. So my clinic is called BioThrive. And like I said, I had doctors with a license in every state. So we do telehealth and pretty much nationwide. There's one or two states that isn't. But if you go to biothrivelife.com, you can contact us and see if it's a good fit. You remember, you need to be able to feel good with your provider, have a
Very
conversation, and you should be able to ask a million questions. And, so we would be honored to help you in your journey, but encourage you to keep knocking on doors until you find the right fit.
Thank you very much. It was
Thank you.
pleasure talking to you. Thanks everyone who spent time with us Friday night.
Yeah,
Busy, busy.
thank you.
See you
Have a beautiful
soon.
weekend.
Take care. Bye-bye.
Bye.
Bye.